Second white coat. Subscribe and like. Let's learn medicine together.
Welcome back. Okay, let's just dive right into this explainer, because today we are modeling the ultimate clinical reasoning pathway for board-style questions. You know, if you're prepping for medical exams, you already know the secret to success isn't just mindlessly memorizing facts, right? It's literally about learning how to read the test writer's mind. So, we're going to dissect a classic clinical vignette step by step. We'll look at exactly how to recognize the disease from those tricky question stems, how to branch your differential diagnoses, and absolutely crucial here, how to confidently eliminate the wrong answer choices. So here's our roadmap for today. First, decoding the question stem. Second, mechanisms of urinary obstruction. Third, eliminating the wrong answers. And finally, the high-yield trap, Priapism. Let's get into it. Act 1, decoding the question stem. All right, here is our vignette. We've got a 68-year-old man in the ED. He hasn't peed in over 24 hours. He reports a year-long history of difficulty initiating urination, plus this feeling of incomplete voiding. On exam, he's got a smooth, enlarged prostate. His creatinine spiked at 2.6. A catheter is placed, instantly draining 800 milliliters of urine, and boom, his symptoms improve, and so does his creatinine the very next day. So the question asks, what is this patient's condition associated with an increased risk for? Is it A, bladder transitional cell carcinoma, B, glomerulonephritis, C, priapism, D, prostatic adenocarcinoma, or E, urinary tract infection? Let's translate this exam speak into actual clinical reality. You really need to drill this equation format into your head. 68-year-old man? Well, that's the classic age for benign prostatic hyperplasia, or BPH. Difficulty initiating urination. That is literally the clinical definition of hesitancy. Suprapubic tenderness and fullness, his bladder is just massively overfilled. And here's the absolute most critical trigger phrase, an enlarged smooth prostate. That word smooth, it's your neon sign for BPH. When you see this specific combo, your brain should immediately lock onto BPH as your primary diagnosis. Moving on to Act 2, mechanisms of urinary obstruction. This brilliantly illustrates the physical domino effect happening inside our patient. It's like a giant plumbing backup. BPH causes this enlarged prostate to basically wrap around the urethra. That creates a static obstruction by physically squeezing the tube, plus a dynamic obstruction as smooth muscle tightens it even further. Now, normally, your bladder contracts and urine flows out completely. But here, the urethra is squeezed completely shut. The bladder pushes and pushes, but eventually, the pressure from the prostate is simply stronger than the bladder's squeeze, so urine flow stops before the bladder is empty. And that fluid has to go somewhere, right? A squeeze tube pushes pressure upstream. The bladder backs up. Then the ureters back up, and that's hydroureter. Finally, the kidneys back up, causing hydronephrosis. This immense back pressure is the exact mechanism causing his postrenal acute kidney injury. Which brings us to this massive number, 800. Draining 800 milliliters of urine immediately via catheter is huge. That completely confirms severe acute urinary retention. When that catheter bypassed his compressed urethra, it basically acted as a pressure release valve. And you know, that's exactly why his symptoms vanished and why that creatinine of 2.6, which was our red flag for postrenal AKI, improved the very next day. We found the blockage, and we relieved it. So the crucial takeaway here is understanding the real-world consequences of that trapped fluid. Because the bladder pressure couldn't overcome the prostate pressure, residual urine just sat there on the bladder. Normally, completely emptying your bladder flushes out bugs. It protects against bacteria. But stagnant residual urine, it creates this warm, nutrient-rich swimming pool for bacteria to just absolutely multiply. Therefore, BPH directly increases the risk for our correct answer, option E, urinary tract infection. Act 3, eliminating the wrong answers. Okay, let's look at option D, prostatic adenocarcinoma. You have to draw a hard line between BPH and prostate cancer. Test writers love this trap. Yes, they both involve the prostate, but they are incredibly different beasts. BPH features a smooth enlargement, and it typically grows in the transitional zone right around the urethra, which, by the way, is exactly why it causes urinary obstruction so early on. And crucially, it does not significantly increase your risk for prostate cancer. Prostate cancer, on the exact other hand, presents as a hard nodular mass on a rectal exam. It usually grows in the peripheral zone, meaning it often doesn't compress the urethra or cause symptoms until much, much later. And here's how we eliminate our other distractors. Option A, bladder transitional cell carcinoma, or TCC. Now, while this does affect the urinary tract, it's classically linked to smoking or occupational exposure to aromatic amines. It has nothing to do with an enlarged prostate. Option B, glomerulonephritis. Well, this is an intrinsic kidney disease affecting the glomeruli directly, completely unrelated to the post-renal, purely plumbing-style obstruction we're seeing here in BPH. Act 4. High-yield trap, priapism. Let's pivot to option C, priapism, which is a massive USMLE trap that you absolutely must understand. What exactly is it? Well, it's defined as a prolonged, usually painful erection lasting greater than 4 hours, happening without sexual stimulation or continuing long after stimulation ends. Normally, blood enters, stimulation ends, blood drains out. Simple. But in priapism, blood enters and gets trapped in the corpora cavernosa. Now, what you need to remember is the underlying physiology. The dangerous type, and the one the boards focus on, is ischemic priapism. It's not just, using it for a long time. It specifically means that this trapped, stagnant blood is rapidly losing oxygen. As oxygen plummets, ischemia sets in, risking permanent tissue necrosis and irreversible erectile dysfunction. This makes ischemic priapism a true red alert urologic emergency. The USMLE absolutely loves to test the specific associations that cause this blood trapping. Always, always look out for a child or young adult with sickle cell disease presenting with a painful erection. Those sickled red blood cells literally physically block the venous drainage. Also, keep an eye out for patients on medications like PDE5 inhibitors, Viagra or sildenafil, which can trap blood if the dose is too high. Other classic causes include antipsychotics, thanks to their alpha blockade effects, and cocaine, which just causes severe vascular dysfunction across the board. And that actually brings us to one of the most classic high-yield pharmacology associations you are ever going to see on an exam: the antidepressant trazodone. If you see a patient taking trazodone in a question stem who suddenly presents with a prolonged, painful erection, boom, you immediately have your answer. To lock this into your brain forever, just use the classic memory hook: trazodone. Trazodone equals erection. I know, it's a completely silly memory trick, but I guarantee it's going to buy you points on test day. All right, to wrap up this explainer, I want you to basically hardwire this super high-yield equation into your brain. Old man plus hesitancy plus incomplete voiding plus a smooth and large prostate equals benign prostatic hyperplasia. And remember, that trapped urine is a swimming pool for bacteria, leading directly to a UTI. By breaking down the question stem, visualizing the physical mechanisms, and analyzing exactly why every distractor is wrong, you build a totally bulletproof clinical reasoning pathway. But I'll leave you with this provocative thought to keep you on your toes. We relied heavily on the word smooth today. If you're rushing through a vignette, or honestly worse, rushing through a real-world physical exam, and you mistakenly interpret a hard, nodular prostate for a smooth one, exactly how quickly will you miss a deadly cancer diagnosis? Stay focused, trust your clinical equations, and keep analyzing every single clue.